Assalamualaikum, respected seniors and dear colleagues. My name is Dr. Mohammed Farhan, and today the topic of our discussion will be acute traumatic spinal cord injuries. So today we are going to discuss the different mechanisms and classification of acute spinal cord injuries, and the systematic and neurological assessment, and the appropriate resuscitation strategies and further management of the acute traumatic spine injuries. So, total incidence of traumatic spinal cord injuries ranges from approximately 20 to 40 million, and it has a bimodal age distribution. Young males, in which the road traffic accidents and high energy velocity traumas are the most common cause, and in the elderly, which are mostly due to the falls. And cervical spine is the most affected area in the whole spine that is usually affected, and it causes greatest disability burden of all levels. Next, on the basis of the pathophysiology, we can divide the spinal cord injury into primary versus secondary. Primary is due to the main impact of the trauma, or the main mechanical trauma at the instant of impact. It may cause compression of the spinal cord, contusion, laceration, or tear in the cord, or just forceful distraction or shearing of the spinal cord, and it leads to the direct axonal disruption and vascular disruption. It is usually reversible, and the target is to prevent, and usually the treatment is not very specific. Next, the secondary spinal cord injuries. It is usually due to the follow-up events that lead to the further injury of the spinal cord, such as the vascular injury, which can cause ischemia and edema. If there is a vascular injury due to the direct impact of the trauma, then it may cause further ischemia and edema, which is usually not affected by the impact. Uh, the ischemia and edema leads to the further progression of the spinal cord injuries. Then ionic dysregulation and excitotoxicity. When there is a vascular disruption, or the cells in the spinal cord or the axons are affected, then excitatory neurotransmitters such as the glutamate or aspartate are released, which causes hyperexcitability of the neurons, leading to influx of the calcium and sodium ions, which cause further disruption of the cellular metabolism, leading to further injury. Then a generation of the free radical generation and lipid peroxidation. Usually, the in the after the impact, when these excitatory neurotransmitters are released, then high energy metabolism occurs, and the oxygen free radicals are formed, and usually the antioxidant pathway is usually also affected in this trauma, which leads to the further increase of the free radical oxygenation and lipid peroxidation, and those different mechanisms due to the free oxygen radical and ionic dysregulation lead to the lipid peroxidation, and this lipid peroxidation can cause demyelination of the neurons or the axons, which leads to the further damage, and ultimately leads to their inability to transmit the to neural transmission. Then the inflammation also occurs. When the vascular disruption occurs, different inflammatory mediators or inflammatory markers are released into the interstitial space and into the axons and the cells, leading to the inflammation pathway, leading to further edema and cytotoxicity. Then different apoptotic pathways are also activated, which leads to the further disruption and cell death. So these are the basic mechanisms of the secondary injury, and this is the visual interpretation of the primary and secondary spinal cord injuries. Primary injury occurs such as contusion, shear, compression, laceration, or stretch, and secondary brain injury due to the vasospasm or ischemia, vascular disruption, excitotoxicity. Mitochondrial disruption can also occur, leading to oxidative damage and lipid peroxidation, neuroinflammation, axonal degeneration, calcium and sodium influx. All these are the basic mechanisms of secondary spinal cord injuries. And then we have the barriers to recovery. Uh, Usually, demyelination occurs, and the glial scar or cyst formation can occur at the area of the ischemia, or at the dead tissue. Then this leading to the inhibition of the regeneration of the axons. Then we can classify the spinal acute traumatic spinal cord injury on the basis of their severity of injury or the involvement of the spinal cord. It can be described into complete injury and incomplete injury. Complete injury, in which there is the complete transaction or the complete damage of the spinal cord. There is no motor or sensory function preserved below the level of the lesion, and there is absent voluntary anal contraction and deep anal pressure corresponds to Asia impairment scale grade A and poor prognosis for functional and neurological recovery. Incomplete injury can occur there when there is a partial motor or sensory function preserved, or there is partial motor or sensory function lost below the level of the injury. Then we can classify them into incomplete spinal cord injury. Then the incomplete spinal cord injury can be described into different syndromes such as the central cord, Brownlee cord, anterior cord, and posterior cord. So we'll describe one by one. The central cord syndrome, in which the central part of the spinal cord is usually affected, and usually there is upper limb weakness is more than the lower limb, and classically after cervical hyperextension, spondylotic canal, and usually occurs in the cervical spine. Then we have the Bromsey-Cord syndrome, in which there is a hemi involvement. There is one side of the spinal cord is usually involved, and there is ipsilateral motor and proprioception loss, but the pain and temperature loss is usually contralateral side. Then we have the anterior cord, in which the anterior part of the spinal cord is usually effective, and bilateral motor loss and associated with the pain or temperature can also occur, but usually the dorsal column or the proprioception senses are usually preserved. Then we have the posterior cord, in which there is loss of the proprioception of the posterior column of the spinal cord is usually involved. uh, Pain and temperature and fine and motor sensations are usually preserved, and the motor sensations or the power is also preserved in posterior cord. Then we can divide the spinal cord injury further into on the basis of the severity of the scale. So the Asia score or the Asia impairment scale can be usually used for the assessment of the spinal cord injury. We can divide it into five categories such as A, B, C, and D and E. In A, there is complete no motor sensory function in the below the level of the lesion, and also in the sacral segments. Sensory incomplete, in which the sensory is usually preserved, but there is no motor function preserved below the level. Then there are motor incomplete. So motor incomplete can be divided into two. Motor function is usually preserved, and sensory function is also preserved, but the motor function, the key muscles below the level of the lesion, or more than half of the muscles involved, are less than grade 3. In D, there is a motor incomplete, in which motor function is preserved, but half of the key muscle below the level are usually greater than grade 3. Then there is E, which is normal, in which motor and sensory function is preserved with no deficit. Then spinal cord injury can also lead to spinal shock and neurogenic shock. In spinal shock, there is temporary loss of all the cord reflexes activity below the lesion. There is a flaccid areflexic paralysis. It is usually not a vascular phenomenon. Usually, the blood pooling occurs due to the muscular paralysis, and there is flaccid paralysis due to which muscle do not contract and the venous pooling occurs. And also there is a complete loss of the reflexes below the level of the lesion, and it usually resolves within hours or days, and then after resolve it can lead to the spasticity of below the level of the lesion. Then neurogenic shock, it usually occurs due to the loss of the sympathetic tone after high injury, usually T6 or above. If levels are involved, then the sympathetic trunk can be injured, or there is disruption in the sympathetic stimulation, which can lead to the loss of the sympathetic tone to the vessels, leading to the hypotension or the dilatation and bradycardia. And is distinguished from hypovolemic shock, that in usually neurogenic shock bradycardia occur, but in hypovolemic shock the tachycardia can occur. It must be distinguished from hypovolemic shock, because if we in bradycardia the fluid overload can occur if we give the excessive fluid, and it usually requires a vasopressors to maintain the blood pressure and cord perfusion. Then, in the assessment of the uh, acute traumatic spinal cord injury, usually the spinal precautions and transport is usually are the key steps in the managing. Such as there should be complete immobilization of the spinal cord and before ruling out any injury, if there is any cervical pain or any pain in the spine or any tenderness, then spinal cord should be completely immobilized, and this can be achieved by the rigid collar or by the spine board until injury is excluded. While shifting the patient or during assessment, log roll can be used. Then spinal cord injury is managed by the usually first by the ATLS protocol. Airway, breathing, circulation are prioritized over the spine exam. When airway, breathing, circulation are maintained, then usually spine examination must be done in all patients to rule out any spinal cord injury, and then the further neurological examination can be done, and then the further investigation such as the X-ray, CT, and MRI can be done. After So the main imaging strategies that CT is the first line, because CT can define the bony alignment and the bony features or the presence of any fracture in the spinal cord, and it is usually easily accessible and can be rapidly done. So CT is the first line choice of investigation in spine injuries. Then MRI can also tell us about the cord, spinal cord, and soft tissues, such different soft tissues such as the disc herniation, ligamentum injury, or any epidural hematoma, or can be assessed, and it can be correlated with the prognosis if there is any hemorrhage or edema. Then, according to the ATLS, as we maintain the airway, breathing, and circulation. In circulation, the management of the shock or the blood pressure is usually very important, because to prevent the secondary spinal cord injury, because if there is a decreased perfusion to the spinal cord, then secondary injury can progress. Usually, the target of should be mean arterial pressure from 75 to 80 to 90 to 95 should be is the target, and usually sustained for 3 to 7 days post injury to optimize the spinal cord perfusion. And when the usually the edema, after that edema settles, so the spinal cord and secondary injury is usually slows down after these days. Uh, so we should avoid hypertension at all costs. Systolic blood pressure should not be less than 90, and treat neurogenic shock actively. Vasopressors can be used, and monitoring in a neurocritical care setting, because in high cervical spine injuries, usually the respiratory problem can also occur. Usually the involvement of the diaphragm or the phrenic nerve can lead to the decreased forced vital capacity. So patient can may need the ventilatory support. Then use of the steroids in the acute traumatic spinal cord injury. Usually the steroids such as the methylprednisolone, different researches have shown that uh, the if a methylprednisolone is given within the 8 hours, usually the time period for giving methylprednisolone is usually 3 to 8 hours, then the 6-month prognosis can be improved. So if considered, then within 8 hours is the recommended dose. Beyond 8 hours or 48-hour infusion is not indicated, and it should be dependent on the shared decision making, such as if there is any suspicion of hyperglycemia, such as in diabetic patient, or if there is an increased risk of infection or pneumonia, if the patient has aspirated, then it should then the weight and harm benefit should be assessed. Then avoid with concomitant traumatic brain injury, because it is associated with increased mortality in combined head and spinal cord injuries. Then the main surgical management we can done in the acute traumatic spinal cord injury is the decompression, because different spinal cord injuries can lead to compression of the spinal cord. So decompression should be done. And usually, if there is a progressive neurological deterioration, of the neurological deterioration is progressing, then decompression should be achieved within the first 24 hours, because it is associated with the greater odds of improvement in the neurology. And in central cord syndrome, if there is a decompression due to the central cord, then within 24 hours can give us a good prognosis. Surgical principles and goals that achieve complete cord decompression, restore alignment and stability, and enable early mobilization, and consider expansion duroplasty in selected cases. Then complications and systemic care. Different, as we have discussed, that cervical spinal cord injury may need respiratory support, because involvement of the phrenic nerve and diaphragm can lead to decreased vital capacity and decreased respiratory effort of the patient. So, cervical spinal cord injury patient should be monitored. Then, spinal cord injury patients are usually immobilized. So, DVT or pulmonary embolism prophylaxis, such as the heparin, can be given, and is usually recommended in the usually started early for the better prognosis. Then, autonomic dysreflexes, such as life-threatening hypotension due to neurogenic shock, can occur. Then skin and bladder pressure injury prevention, bed sores, such as the bed sores, and bowel or bladder prognosis from day one should also be assessed. Then after the acute management, rehabilitation and prognosis, it involves multidisciplinary rehabilitation, such as the physiotherapy, occupational therapy, and psychological support should be started as early as possible. And grade at presentation predicts outcome. Incomplete injuries can usually recover, but the complete cord injuries are usually have the poor prognosis. Most neurological recovery occurs early, that within 6 to 12 months can occur, and lifelong surveillance is required for cardiovascular, mental health, and bladder, bowel, or skin after spinal cord injuries. So we have discussed so the key points in this, that after spinal cord injury, the secondary spinal cord injury should be prevented. Patient should be maintained first according to the ATLS protocol. Then spine should be immobilized after maintenance of the blood pressure to prevent secondary injury, and then surgical decompression if required. So thank you very much. This was today's presentation. Any questions or any comments?
There is a cord contusion basically, and there is no compression as such. There is no traumatic disc. There is no fracture. But there is a trauma due to multiple degenerative features. When there is a trauma, there is central cord syndrome. There is contusion inside the center of the cord. So even in those cases, you will go for the decompression. And what kind of decompression you will like to achieve?
Central cord usually occurs due to hyperextension injury. If there is any osteophyte present, then if there is no decompression, then there is no need to do the. If there is no compression, then decompression is usually not done or not required. But if there is decompression, then due to any osteophyte or any traumatic disc herniation, we can do the decompression.
Okay, that's great. Dr. Vikas, what is the difference between neurogenic shock and spinal shock? टर्म में ये शॉक नहीं है, ये स्पाइनल कॉर्ड के रिफ्लेक्सेस खत्म हो जाते हैं, सेंसरी मोटर बिलो बिल्कुल फ्लैसिड होगा। तो उस शॉक को जिसके अंदर आपकी सेंसरी मोटर एक्टिविटीज़ ख़त्म हो जाए उसको स्पाइनल शॉक बोलेंगे। बट ऐसे ये वो शॉक नहीं है जो हम रूटीन में डिफरेंट शॉक्स पढ़ते हैं। उन शॉक्स का ना न्यूरोजेनिक शॉक आता है जिसमें आपको हाइपरटेंशन और बाकी चीज़ें मिलेंगी। Spinal shock is basically it's a shock of the spinal cord, you can say.
I have few comments on your presentation. First of all, was it spine or spinal cord?
Spinal cord, sir.
आप इसको दोनों को ना कंफ्यूज कर रहे थे, कभी स्पाइन और कभी स्पाइनल कार्ड।
सर वो अनइंटेंशनली वर्ड जो है वो स्पाइन निकल निकल रहा होगा, लेकिन स्पाइनल
बेसिकली
कॉर्ड के लिए।
आपकी जो प्रेजेंटेशन है वो स्पाइनल कार्ड इंजरी थी, ठीक है। उसमें मैंने ये फील किया कि आपकी जो प्रेजेंटेशन है ना, ये एक जनरलाइज सी प्रेजेंटेशन थी, क्योंकि इसमें मल्टीपल टॉपिक हो सकते हैं। जिस तरह से आपकी ये सेंट्रल कार्ड है, ब्राउन कार्ड है, ये आपने बिल्कुल एक सरसरी सा किया है। इसमें अगर आप थोड़ा सा पहले एक्सप्लेन करते हैं ना कि ट्रैक्स कौन से हैं, असेंडिंग डिसेंडिंग, फिर उनकी पिक्चर से लोकेशन क्या है, कि अगर आपकी ब्राउन कार्ड है तो उसमें कौन सा ट्रैक्ट इन्वॉल्व है, अगर इंटीरियर है, पोस्टीरियर है, सेंट्रल है, सेंट्रल की क्या मैकेनिज्म है, तो फिर वो कंपैरेटिवली ज़्यादा बेटर होना था। तो सेकंड ये है कि हमने ये देखा कि देर इज़ सेकेंडरी स्पाइनल कार्ड इंजरी, उसके तीन आपने वेज बताए, ठीक है। एक उसमें एक्साइटो टॉक्सिसिटी है,
एक्साइटोटॉक्सिसिटी।
ठीक है। उसके बाद फ्री रेडिकल फॉर्मेशन है, उसके बाद स्कीमिया। इज़ देयर एनी वे टू प्रिवेंट दीज इंजरीज? क्लिनिकल
यस
प्रैक्टिस में हमको यूज़ करते हैं कि ये एक्साइटोटॉक्सिसिटी है या फ्री रेडिकल फॉर्मेशन है, इसके लिए हमको मेडिसिन देते हैं या क्या करते हैं?
सर, डिफरेंट newer medications are available which prevent the free oxygen radical formation, such as the rulazine is usually the latest which is in development, and different others are also in development. uh, the names I cannot recall now, but I'll check.
एक इसमें जो इन्फ्लेमेटरी कैस्केड है उसको रोकने के लिए कोई मेडिसिन यूज़ की जा सकती
Yes, sir. Usually the steroid mechanism, methylprednisolone, has the same mechanism, that is anti-inflammatory, and it can also inhibit the lipid peroxidation or leading to demyelination.
है? दूसरा आपने ये डिस्कस किया कि मिथाइल प्रेडनिसोलोन शुड बी गिवन विद इन द 8 आवर्स। मैकेनिज्म इसकी क्या, लॉजिकली क्या है?
Sir, so that three researches were done on this. That first they compare the methylprednisolone versus with the uh, uh, there were two comparison with methylprednisolone and without methylprednisolone. So the methylprednisolone overall the effect was not appreciated, but when they given within 48 hours, uh, analysis on the 48 hours, then methylprednisolone has a better outcome. Uh, then they do the second time research on within 48 hours and after 48 hours. Then methylprednisolone had shown a better good outcome in 48 hours, in 8 hours in the further analysis. Then they compared the 8 hours research with the 48 hours. The 8 hours further showed that the methylprednisolone within given within 3 to 8 hours had a better outcome.
स्पाइन में भी अब ये बहुत ही डिबेटेबल है। ब्रेन में तो ट्रॉमा में बिल्कुल नहीं दे सकते, स्पाइन में भी अभी कुछ जगहों पे देते हैं, कुछ भी नहीं देते। डॉक्टर मोहसिन साहब ठीक कह रहे हैं, हम स्टडी कंडक्ट कर सकते हैं मिथाइल प्रेडनिसोलोन को, जो भी एक इसका 30 मिलीग्राम पर केजी स्टार्ट में देना होता है, फिर आई थिंक 5.4 मिलीग्राम एक वो लोडिंग डोज है जो कि सब्सिक्वेंटली आगे चलेगी। एक ये बस मेरा एक लास्ट क्वेश्चन है, उसके बाद वी आर गोइंग टू कंक्लूड। व्हाट इज़ द डिफरेंस बिटवीन न्यूरोजेनिक शॉक एंड ऑटोनोमिक डिसरिफ्लेक्सिया? अगर ऊपर इंजरी है ना, ये आपको क्लिनिकली आपको बहुत ज़्यादा मिलेगा। आपने कोई स्पाइनल कॉर्ड इंजरी का पेशेंट दाखिल किया है ना, और आपकी आपकी इंजरी का लेवल T6 से ऊपर है, ठीक है, मेरी बात आप समझ रहे हैं? तो ऑटोनोमिक डिसरिफ्लेक्सिया बेसिकली उसमें क्या होता है कि आपको पता है ज़्यादा जो स्प्लैंक्निक वस्कुलेचर है वो T5 से लेकर L2 तक है, नीचे है। तो जिस जब इससे ऊपर इंजरी होगी ना, तो वो जो इनहिबिटरी रिस्पॉन्स आ रहा होता है ऊपर ब्रेन से वो जाएगा नहीं, बिकॉज इनहिबिट वो यहाँ तो इंजरी है। तो उससे नीचे हल्का सा कोई ट्रॉमा या कोई फोलिस डिस्टेंडेड है या उसको कोई पेन है या कोई बेड सोर है या वैसे उसको कोई इंजेक्शन या कोई चीज़ नीचे लगी है, तो एकदम से सिंपैथेटिक डिस्चार्ज होगा, एक्सट्रीम सिंपैथेटिक इन्फ्लक्स आता है बॉडी के अंदर। लेकिन उसकी इनहिबिशन ऊपर से नहीं आ रही होती, क्यों कि इंजरी हो चुकी है ऑलरेडी। तो पेशेंट को क्या होता है, जब इतनी ज़्यादा सिंपैथेटिक वो होता है तो वो एक ब्लड प्रेशर एकदम से पेशेंट का बढ़ता है। ये कैटाकोलमिन सर्ज या सिंपैथेटिक स्टिमुलस एकदम से ज़्यादा हो तो क्या होगा, क्या होगा फिर इंक्रीज होगा, एक्सट्रीमली इंक्रीज इन ब्लड प्रेशर होगा। तो उसमें क्या होता है, पेशेंट का ब्लड प्रेशर इवन 200 से ऊपर चला जाता है, फ्लशिंग हो रही होती है फेस की, पेशेंट इतना इरिटेबल होता है हद से ज़्यादा। तो उसमें क्या क्या करना होता है, फ़ौरन पेशेंट को आपने स्ट्रेट ऊपर करना होता है, हेडअप, फ़ौरन पेशेंट का हेडअप करें, ठीक है। और फिर मेक श्योर करें कि कोई ऐसी स्टिमुलस तो नहीं है जिससे पेशेंट इरिटेट हो रहा। मोस्ट लाइकली वो फोलिस कैथेटर होता है। अगर वो ब्लॉक है तो उसको अनब्लॉक करें, अगर उसको चेंज करना है या उसको निकालना है या कोई आईवी लाइन है तो स्टाफ को कहें कि ऊपर कर दे, यानी कि उससे नीचे नीचे कोई ऐसा स्टिमुलस ना हो जो पेशेंट को एक स्टिमुलस के तौर पे, पेन स्टिमुलस के तौर पे एक्ट कर रहा हो। और उसमें आपने फ़ौरन ब्लड प्रेशर को लोअर करने के लिए मेडिसिन देनी होती है, ठीक है। वो कहते हैं कि नाइट्रोग्लिसरीन का जो पैच होता है वो लगाएं या फिर निफेडिपिन जो च्यूब कर सकते हैं वो दें। हम फिर कैपेटिन वगैरह देते हैं ताकि उसका ब्लड प्रेशर एकदम से कम हो। तो ऑटोनोमिक डिसरिफ्लेक्सिया में हाई ब्लड प्रेशर है अगर T6 से ऊपर इंजरी है, और न्यूरोजेनिक, और ये आफ्टर वीक्स होता है। लेकिन मैंने अपनी क्लिनिकल प्रैक्टिस में देखा कि जो पेशेंट हमारे पास एडमिटेड होते हैं ना, तो विद इन 7 डेज़ भी मैंने इसको देखा कि पेशेंट को एकदम से, यंग पेशेंट था और उसको एकदम से ब्लड प्रेशर, स्टाफ ने कहा कि सर उसका 200 से ऊपर ब्लड प्रेशर हो गया और पेशेंट बहुत ज़्यादा इरिटेबल है, फ्लशिंग और फेस उसका ऐसे रेड हुआ। तो उसमें आपने फिर उसका ब्लड प्रेशर लोअर करने के लिए क्विकली जितना कर सकते हैं वो सारी चीज़ें, तो ये आपको कॉमनली मिलेगा। तो ऑटोनोमिक डिसरिफ्लेक्सिया इज हाइपरटेंशन ड्यू टू अ स्टिमुलस बिलो द T6, क्योंकि इनहिबिशन है ना T6 से ऊपर से, तो वो आ ही नहीं रहा। और ये वस्कुलेचर मैक्सिमम हमारा नीचे है, तो सिंपैथेटिक स्टिमुलस वेजो कंस्ट्रिक्शन होगी, इतनी ज़्यादा ब्लड सप्लाई वेजो कंस्ट्रिक्ट हो जाए तो ऊपर ब्लड प्रेशर एकदम से हाई हो जाएगा, ठीक है। तो और जो न्यूरोजेनिक शॉक में क्या है, वो तो एक प्रॉपर शॉक है बेसिकली। यस, उसमें आपने क्या करना होगा, यस, और इसमें हमने, यस, उसमें हमने ब्लड प्रेशर बढ़ाना है, इसमें ब्लड प्रेशर कम करना है हमने, तो दोनों में डिफरेंस है। और कुछ कोई कमेंट करना चाहिए डॉक्टर वकास?